Welcome back to part 8 of our breast surgery coding masterclass. So in this explainer, we're transitioning from the duct surgery we covered last time and jumping right into one of the absolute most heavily audited areas in CPT surgery coding. I'm talking about the open surgical excision of breast lesions. We're going to break down the critical differences between palpable and non-palpable mass resections straight from our source material. Let's get into it. Okay. Let's take a quick look at today's agenda. We're covering anatomy in our masterclass intro, breast localization devices, open surgical breast biopsies, marker-directed lesion excision, partial mastectomy coding rules, and finally some live coding case scenarios. Starting off with Section 1, Anatomy and Masterclass Intro. Now take a look at the circular body of the breast here, with its really intricate network of lobes and ducts, right alongside the axillary tail, which is also known as the tail of Spence. You can see how it runs straight toward the axillary foss's lymph nodes. Understanding these distinct zones is totally vital, guys, because your operative documentation is going to frequently reference these specific anatomical areas when the surgeon describes exactly where a lesion is located. And here we're looking at the sentinel lymph node pathway. Think of this as the gateway. It's defined as the very first node that cancer cells are most likely to spread to from a primary tumor. So, when you're reading a report and you see documentation of radioactive seed or dye injections used to trace this exact pathway, well, you know for sure the surgeon is staging the axilla to determine the clinical extent of the disease. Moving right along to Section 2, Breast Localization Devices. All right, this brings us to a highly tested area, targeting the non-palpable mass. The absolutely crucial point to remember here is choosing your primary and add-on codes based entirely on the specific imaging guidance used, whether that's mammographic or stereotactic. So for mammographic guidance, we look to CPT 19281 for the first lesion, and then the add-on code 19282 for any additional lesions. But if stereotactic guidance is used, we shift gears over to 19283 and its add-on 19284. Basically, the guidance type dictates the entire code family. Let's really break this down because, trust me, this is a massive audit gotcha. You always report the code based on the number of targeted lesions, not the number of devices placed. A single complex lesion might actually require 2 or 3 wires to bracket it properly. You do not code based on the number of wires. Just count the lesions and then apply your add-on codes for each additional lesion accordingly. It's as simple as that. And hey, modifier placement here is incredibly specific. Do not use modifier 50. If devices are placed in 2 distinct lesions across opposite breasts using the same guidance, you literally just use your primary code and an add-on code without a 50 modifier. However, you do use 59 or XE if the surgeon places a device in a separate suite, or maybe a preoperative holding area right before transitioning the patient to the OR for a mastectomy. Let's transition to Section 3, Open Surgical Breast Biopsies. So when the surgeon opens the skin specifically just to take an incisional tissue sample, meaning they are only cutting out a piece to test it, not removing the entire mass, we reach for CPT 19101. This is an open approach, which makes it totally different from a percutaneous needle core biopsy. And take note of this, you actually do append modifier 50 to 19101 if this open incisional biopsy is performed bilaterally. All right, escalating now to Section 4, Marker-directed lesion excision. You've really got to notice the difference in clinical intent here. 1910-1 is just taking a tiny sample. But if the surgeon is performing a complete excision, you have to identify the main clinical deciding factor. Is the mass palpable or non-palpable? If the surgeon removes a palpable mass that can physically feel without needing any radiological marker, that open enucleation points us directly to CPT 19120. But if the mass is non-palpable and requires a preoperative marker, like a hook wire or a Savvy Scout reflector, 1925 becomes our primary anchor for that gross, complete excision. You really need to keep these strict coding rules in mind for marker-directed excisions. You're going to use add-on code 19126 for each additional marked lesion. But remember, this is completely different from palpable resections. For CPT 19120, the code definition actually says 1 or more lesions. So removing 2 palpable fibroadenomas through the exact same operative field is billed as just a single unit. For both of these codes, removing separate lesions through a single surgical incision means you only report the primary excision code once. You only start looking at modifiers if separate, distinct incisions are made in different quadrants. And finally, unlike localization codes, you actually do append modifier 50 to 19125 if it's performed bilaterally. Next up is Section 5, Partial Mastectomy Coding Rules. Now, as we escalate all the way up to oncologic resection, let's see how this anatomy builds our understanding of CPT 19302. You can clearly see the low axillary level 1 nodes, the mid-axillary level 2 nodes tucked right behind the pectoralis minor, and the high axillary level 3 nodes. What you need to know is that CPT 19302 requires a full-blown dissection of these axillary nodes, not just a localized sampling. So, while there isn't some strict absolute number of nodes that have to be removed and documented to report code 19302, the golden rule here is that the surgical dissection absolutely must encompass levels I and I at a minimum. If they're only removing a single sentinel node, you do not code 19302. Instead, you'd code a standard partial mastectomy alongside a sentinel node biopsy. All right, let's put this into practice with Section 6 live coding case scenarios. Okay, consider this real-world operative case. We have two separate sets of non-palpable microcalcifications in the left breast. Using stereotactic guidance, individual hook wires are placed into both areas, say at 12 o'clock and 4 o'clock. So how would you code the targeting phase of this surgery, keeping in mind the guidance type and the number of lesions? Let's walk through it. Because stereotactic guidance was used for two completely distinct lesions, we accurately apply the primary code 19283 for that first lesion and the add-on code 19284 for the second one. Remember our golden rule here. We count the lesions, not the wires. And of course, the stereotactic guidance is what dictates this specific CPT family. I bet you nailed it. Wow, what an explainer. We've successfully navigated the entire escalation arc of breast surgery coding today. From targeting those non-palpable lesions, to open sampling, all the way up to complete marker-directed removal and partial mastectomies. Seriously, use the rules we covered in this explainer as your ultimate audit checklist. They will save you so much time. Are you ready to tackle male breast surgery next? Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Herschel. See you in Part 9.